Hello, everybody. I'm so glad to be here with you from a remote location. My name is Tom Beer, and I'm Deputy Director of the OHSU Knight Cancer Institute, where I also lead the prostate cancer program. And I'm pleased to be here with you to discuss PSMA imaging and therapy, as well as targeted therapy in advanced prostate cancer. Before we dive into the slides, I'd like to put this talk a little bit in context. What we're going to be talking about is primarily therapy for the most advanced form of prostate cancer, sometimes referred to as hormone refractory prostate cancer or castration-resistant prostate cancer. So these will be latest data on relatively new treatments or even upcoming treatments for the metastatic form of prostate cancer. As you know, when we think about prostate cancer, there is a spectrum of the disease, beginning with early, newly diagnosed, hopefully localized prostate cancer, where the discussion is about whether local treatment is necessary or observation is an alternative. And the goal there is cure. As the disease becomes more advanced, we deal with recurrences and metastatic disease, metastatic meaning spread to distant organs. There, the mainstay of therapy is hormonal. And as the disease becomes resistant to hormonal therapy, that's when we begin to think about chemotherapy, second-line hormonal agents, radiopharmaceuticals, and novel targeted drugs. That's the situation that we'll be talking about today. One of the most exciting areas in this field is developments around PSMA, or prostate-specific membrane antigen. PSMA is a unique protein that sits in the cell membrane, which means it has a large domain that's outside of the cell and visible to drugs and antibodies, and therefore can be targeted both for imaging and for therapy. And the illustration here shows you roughly what it looks like. Those little blue bubbles, that's the cell membrane, that's the edge of the cell, and the big colorful component is the extracellular domain to which the drugs and imaging agents are targeted. It is highly expressed in prostate cancer, including metastatic disease. It is more expressed in more advanced prostate cancer. There is some expression of it in normal organs, particularly salivary glands where saliva is made and lacrimal glands where tears are made. So it's not entirely prostate specific, but it's quite prostate specific. And so it's an excellent target for PET imaging and therapy, but we need to be aware what normal parts of the human body it is also expressed in. In the first part of this talk, I'd like to briefly discuss some of the developments in using PSMA for imaging. And I certainly won't be covering all aspects of that, and I'm grateful to my colleagues whose slides I was able to borrow to include in this talk. So first, let's think about the spectrum of the disease and what the imaging priorities are in the various situations that folks find themselves in with prostate cancer. Looking from left to right, when we think about clinically localized disease, their imaging can help us develop a more precise definition of the extent of disease, prognosis, and plan therapy better. So those are the primary goals in localized disease. In recurrent disease, rising PSA in particular, imaging can help us identify whether the recurrence is related to local disease or whether there are distant metastases that are beginning to develop that might not be visible by conventional imaging. And finally, in metastatic disease, we use imaging both to quantify the disease, localize it, know where it is, know how much disease we're dealing with. Importantly, to follow the disease through therapy and determine if it's responding or not. And in the case of PSMA-directed therapies, we also use imaging to determine that an individual's prostate cancer expresses PSMA and therefore can be targeted using PSMA Therapeutics. So that's how we think about imaging in prostate cancer. I'm going to show you a couple of slides of PSMA PET scans, which are the latest form of imaging in prostate cancer that exploits PSMA, and how they perform in patients with a rising PSA. So that's a specific setting. Patients who've had surgery or radiation now have a rising PSA. Conventional imaging is not showing us any disease or is not clearly showing us disease. When we get a PSMA PET scan, however, it is quite common for us to find a lesion that is at least partially responsible for the rise in the PSA. And this is, these are data presented by Rob Reiter at the ASCO meeting a couple of years ago from UCLA and UCSF, where they used gallium-68 PSMA imaging. And you can see the proportion of patients where a lesion was found on the vertical axis, shown across a range of PSAs. So even for folks with a PSA recurrence under 0.5, those investigators found some abnormality on PSMA imaging is just under 40% of patients. And when you look at folks with a PSA above 2, more than 80% of them had a visible lesion on PSMA PET scan. And you can see the distribution of those lesions. In light blue, you can see prostate bed, in orange yellow pelvic nodes, and then in the other colors, different areas of distant metastases. So these kind of results help us determine whether radiation-based salvage treatment makes sense, and if so, where one might aim it. Some of the specific examples of how you might use the results of such PSMA imaging are listed here. So for example, if the signal is in the prostate bed only, that might allow treating physicians to target the treatment to the prostate bed and to avoid systemic therapy or radiation treatment to other sites. If pelvic or regional lymph nodes are identified, that would also allow a more thoughtful targeting of radiation and would certainly impact on the choice of the radiation field. Oligometastatic disease is a relatively new entity that we think about. That's a situation where, while the cancer has spread to distant sites, oligo means few and means there are relatively few sites of disease. And there, clinical trials are evaluating metastasis-directed radiation therapy, also known as SBRT. And the goal there can be to control the disease without hormone therapy for a period of time, by some time before hormonal therapy is necessary, or potentially to get a better outcome than hormonal therapy alone. And that approach is still investigational. Definitive phase 3 trials have not been reported, but early results from phase 2 trials are encouraging, and many practitioners are offering that approach. And of course, if we find a larger volume of distant metastatic disease, then treatment can focus on systemic therapy and avoid radiation that would be unhelpful. Here are results of another study using fluoride-18 PSMA. This is a recently approved PSMA contrast agent, also known by some as Pylarify. Here, patients with a rising PSA after definitive therapy, in other words, therapy with curative intent, either prostatectomy or radiation, who did not have clear evidence of metastases on conventional imaging, were evaluated using the F18 PSMA PET. Some of these folks may have had equivocal findings on conventional imaging, but none of them had definitive evidence of metastases. And again, on the left-hand side, you can see the lesion detection rate by PSA, and similar results to what we saw with the gallium. Upwards of 40% of patients with a PSA under 0.5 had detectable lesions, and over 80% of patients had detectable lesions if their PSA was above 2. On the right-hand side, you can see that using a combined standard to determine whether the localization rate was correct or not, the large majority of the lesions were correct. And this was determined primarily by either a pathologic evaluation, a biopsy, or by response to lesion-directed radiation. But these results do give us quite a bit of confidence that a large majority of the lesions on these high sensitivity PSMA PET scans do indeed represent a finding of a metastatic spot from prostate cancer. This is a look at the impact on PSMA imaging on patient management. Now, this is not the same as patient benefit. This is just looking at the question of whether physicians and patients chose a different approach based on the results of their imaging study. And the long and short of it is about 2/3 of patients had some change in their management plan as a consequence of imaging. And these changes occurred both as a consequence of a positive scan, a scan that identified lesions, as well as a negative scan. So what settings is this new PSMA PET imaging appropriate? Well, there's a lot of data to be gathered, and definitive evidence of clinical benefit to patients remains to be determined in many settings. But the Society for Nuclear Medicine convened a multidisciplinary group to look at so-called appropriateness scenarios for PSMA PET imaging. This was an opinion-based conclusion. This was not a scientific review with stringent criteria. It did, of course, rely on the scientific literature, but ultimately it was the interpretation of the members of this group. And so you can see that at the moment, prior to diagnosis, or for men with low or very low risk prostate cancer, there really aren't clear indications for PSMA PET. And in the other disease states, the group felt that PSMA PET imaging can be appropriate or may be appropriate, which is kind of a step in between not appropriate and definitely appropriate. That, of course, does not mean that every single patient needs this type of imaging. And I think that's an important point to make. But it does point out that newly diagnosed high intermediate and high risk patients, as well as patients with a rising PSA, either on hormonal therapy or not, are deemed as appropriate to image with PSMA PET imaging. And this is really a change in the field. These agents are coming into use in late 2021 and early 2022, and we're seeing a considerable change in how we approach these groups of patients now that we have high sensitivity imaging available to us. In this part of the talk, I'm going to shift gears and talk a bit about how we've exploited the PSMA protein for therapeutics. And so here we'll be talking about lutetium, PSMA 617, and other targeted therapies. Most of what I'll be talking about is the use of a PSMA binding agent called PSMA 617 to deliver a radioactive moiety or radiopharmaceutical to the tumor, in this case, lutetium 177. The idea here is that the binder binds to prostate cancer cells, is internalized, and the radiation is delivered directly to where it needs to go, avoiding most of the other parts of the body where we don't want radiation delivered. I will point out, and we won't have any data to discuss today, that PSMA is not just a target for radioactive molecules. It's being evaluated as a target in a variety of ways, including immunotherapeutics. And here's a listing of companies that have and names of experimental agents that are being evaluated to see if immunotherapy can be brought to bear using PSMA as a target. And these are particularly biologically interesting ideas where antibodies are custom designed to attach both to the PSMA molecule on the surface of a cancer cell and something like a CD3 molecule, which is expressed on the surface of a T cell, an immune T cell, brings the two together and induces those immune T cells to attack the prostate cancer cells. A number of these agents are in phase 1 and phase 2 clinical trials, and time will tell how they will pan out, but there's a lot of interest in using PSMA in a variety of ways for therapeutics. The furthest along, though, is the concept of targeting PSMA to deliver therapeutic radiation. And here's a New England Journal paper, lutetium-177 PSMA-617, that was published in the summer of 2021. I had the distinct privilege of being part of the investigative group that worked on this clinical trial, and was very, very glad to be in this august company. This slide here summarizes the design of this study. There's a lot on the slide, but let me try to walk you through it. First of all, on the left-hand side, you can see which patients were eligible. And so these were patients with metastatic, castration-resistant or hormone-resistant prostate cancer. They had to be progressing, and they had received at least one next generation hormonal agent and at least one taxane chemotherapeutic. So these were folks who'd been extensively treated for their prostate cancer upfront and when the disease became resistant to therapy. Patients were randomly assigned to a standard of care plus lutetium PSMA or a standard of care alone. Now, standard of care was really at the discretion of the treating physicians, but could not include chemotherapy, immunotherapy, radium-223, or investigational drugs, because those agents had not yet been safely combined with lutetium PSMA, and so we couldn't safely advocate for their use in combination. So as a practical matter, most patients in the control condition received a second-line hormonal type drug. Patients received regular follow-up, of course, and they were followed both for overall survival and progression-free survival. Progression-free survival being a measure of how long it takes before there's radiographic evidence that the cancer is progressing. All patients to participate in this study had to be qualified on the basis of a PSMA imaging study. In other words, we had to know that their tumor expresses PSMA. So in this table, we begin to show you the types of patients that were registered to this study, and it looks separately at the subset of patients that were analyzed for progression, and on the right-hand side, all patients that were included in the survival analysis. I think the numbers are quite similar, and I'd encourage you just to take a look at the right side of the table, which is more inclusive. And you can get a sense of the folks that were involved here. The average age was around 70. Most patients were Caucasian, but other races were also represented. Most patients had a good performance status. An ECOG of 0 or 1 means somebody who has few symptoms and is relatively active. Of course, 90+% of patients had bone metastases, and about half the patients had lymph node metastases, and 10% lung and 13% liver. So pretty typical distribution of disease for this advanced form of prostate cancer after several lines of treatment. This is the primary endpoint and shows overall survival. So this is really the proof in the pudding. This is how long people were able to stay alive. Now, this was a very difficult group of patients to treat. These were folks that had a very aggressive cancer. And so the median survival in the control condition was under a year. It was extended by about 4 months of the median, or 38% as a consequence of treatment. When we look at these kinds of survival advantages, one of the things that we want to know is the benefit apparent across a full range of potential patients. And so we look in these subgroup analyses. And if you see one of these plots, what you can see is an axis with a line on the 1, and any dots to the left suggest a benefit in the experimental arm, the lutetium arm, and any dots to the right of the line would suggest that the placebo did better, indicating that lutetium did not have a benefit. And then the lines around those dots are so-called confidence intervals. That's a statistical measure of how robust the estimate is. In these subset analyses, we do not expect statistical significance. The studies are designed to measure effects in the entire group, so we don't worry a whole lot about wide confidence intervals. We just want to see that the estimate is directionally consistent. And so you can see that really, regardless of what therapy was planned in combination with lutetium, regardless of prognostic factors like LDH, liver metastases, worse performance status, older age, we really saw a consistent favorable impact on overall survival. Looking at the racial makeup, Caucasians and African Americans appeared to benefit equally. Hard to know what to make of the Asian subset. That was 20 patients out of 800, and one wouldn't really draw definitive conclusions from such a small subset, but that was the only group where we didn't see a clear movement in the needle to the left of the 1 line. This is progression-free survival here. This is the time to evidence that the cancer is progressing on imaging, bone scans, or CAT scans. The hazard ratio here is 0.4, meaning a 60% improvement in the risk of progression, and at the median, that number is moved from 3.4 to 8.7 months. Now, obviously, we want to be gaining more, and we would like these progression-free survival numbers and overall survival numbers to be measured in years and not months. But this is a pretty substantial difference when considering that these folks had few treatment options available to them, and the fact that these kinds of analyses that you can see here include all patients, including those patients who may not have responded to treatment. These are kind of the most complete ways to analyze these treatment effects. Here's a slide that looks at measurable disease, or so-called RECIST responses. So this is a situation where you can see the tumor on a CAT scan, you can measure it with a ruler or an electronic ruler, and you can determine whether the tumor shrank or not. So this is not PSA, this is actually visible lesions in the liver or lymph nodes or lungs, and did they shrink or not. And in the blue, you can see lutetium, and in the yellow, you can see the control condition. And so the labels, unfortunately, are not correct on the colors. So that must have flipped over as we changed the slide color scheme. So you can see that when it comes to complete or partial response, about 50% of patients treated with lutetium had a complete or partial response. Another 35% had stable disease. Whereas in the control condition, there were no complete responses. Partial responses were rare, and pretty much half the patients had stable disease and half progressed straight away. So pretty clear difference with regard to measurable disease response on imaging. And this is PSA effects. These look like blotches on a slide. They're actually a series of bars or lines, one for each patient. These are so-called waterfall plots. And so what you want to see in these is color below the 0 line. That shows that the PSA dropped in that individual patient. So you can see on the left-hand side for the lutetium group, the majority of patients, the blue is below the line, meaning the PSA dropped on therapy. Whereas for the standard of care, the majority of the yellow is above the line, meaning the PSA continued to go up on therapy. And if you look at what fraction of patients met the definition of a response, which is a confirmed 50% reduction in the PSA, was 46% for lutetium and 7.1% for the control arm. So very clear difference, not just in measurable disease response, but also in PSA response. So how did the safety of these treatments compare? What is the safety signal from lutetium? No treatment comes without some cost and side effects. And so you can see in this table columns for lutetium and standard of care. And on the left-hand side, you can see all grades, meaning mild to severe toxicity. And on the right-hand side, you can see the frequency of severe toxicity. Grade 3 is moderate, grade 4 is severe. And grade 5 is death due to treatment, so obviously the most severe possible. So you can see that fatigue was increased with lutetium compared to standard of care. Not unexpectedly, there was evidence of bone marrow suppression. So those are things like low white blood cell counts, anemia, low platelet counts. Thankfully, when you look on the right-hand side at the more severe grades, it was relatively uncommon. Importantly, because PSMA is expressed in salivary glands that are responsible for the production of saliva, and also in the gastrointestinal tract, we expect dry mouth and we expect some nausea, and we saw that. There's also a small increased risk of kidney dysfunction with lutetium PSMA compared to standard of care. So from this vision study, what the authors concluded was that lutetium PSMA could safely be combined with primarily a hormonal standard of care in patients with advanced metastatic castration-resistant prostate cancer. And it resulted in an extension of survival and a delay in disease progression. It was generally well tolerated with side effects that one would expect based on the mechanism of action of this drug. And it was the view of the authors of this presentation, as well as most of us in the field, that these findings are sufficient to recommend adoption of this agent into the care of prostate cancer patients. The company making this drug has filed an FDA application, and as of the time of this recording, we're awaiting decisions from the FDA about the availability of lutetium PSMA for patients with prostate cancer. And most of us are hopeful that we'll see this approved and available in the coming months. Now, one of the criticisms of the VISION trial is that the control arm was not necessarily the most active option. It included second-line hormonal agents, but it did not include radium-223 or second-line chemotherapy, for example. And there were good reasons for that. And many of the patients on the VISION trial had actually gotten 2 lines of chemotherapy already. Nevertheless, some critics of the trial felt that a comparison to a different control arm would have been of interest. And the therapy study reported by Dr. Hoffman here in 2020 really began to address that question. This smaller study compared lutetium PSMA 617 to second-line chemotherapy with cabazitaxel. The folks enrolled on this trial were similar to the prior trial in that they had metastatic hormone or castration-resistant prostate cancer that was progressing and had to be previously treated with docetaxel chemotherapy and capable of receiving second-line chemotherapy with cabazitaxel. They also had to qualify for treatment with a PSMA PET scan that showed PSMA-avid disease. This was a much smaller study, 200 men in 1-to-1 randomization, and the study was carried out in Australia. The primary design of the study was to look at PSA response. So not a definitive survival study. And this was too small a study to do that. Having said that, it yielded encouraging results. This is the primary endpoint, PSA response, and another waterfall plot looks a little bit different directionally than what I showed you for the VISION trial, but you can see on the left-hand side, cabazitaxel, and in red, the subset of patients who qualified for a confirmed response, and that was 37% of patients. That's what you expect from cabazitaxel in this setting. On the right-hand side, you can see lutetium PSMA, response rate of 66%, and you can certainly visually see a clear difference between these two waterfalls. When looking at progression-free survival, the hazard ratio was 0.69, indicating a 30% improvement in progression-free survival between lutetium PSMA and cabazitaxel. So while this study is not able to definitively look at overall survival, I think it complements the VISION trial and gives us some confidence that even when put up against cabazitaxel, the best available therapy for patients with the most advanced prostate cancer, we see evidence of a higher level of activity with lutetium PSMA that most of us would expect to translate into a clinical benefit if it had been studied in a larger study capable of measuring things like overall survival. Here we have a little bit of toxicity data as well. You can see that we're seeing expected side effects. Of course, with cabazitaxel, you get a little bit more toxicity than you do with second-line hormonal therapy. So for example, diarrhea is a fairly common side effect of cabazitaxel, as is neuropathy and changes in taste. Those are uncommon with lutetium, but we do see low platelets and dry mouth, as well as dry eyes with lutetium, as you'd expect based on where PSMA is expressed in the human body. So the authors of the therapy study concluded that in men with metastatic castration-resistant prostate cancer who had previously received chemotherapy, lutetium PSMA was superior to cabazitaxel as measured by PSA response rate and PSA progression-free survival, and achieved those advantages with fewer grade 3 or 4 or severe adverse effects. So that's the update on PSMA Therapeutics. I have a few minutes left, so I wanted to switch gears and tell you a little bit more about another family of targeted therapies, so-called PARP inhibitors, because these are now becoming a reality in prostate cancer. And the work here began with this genomic map of advanced prostate cancer. This was a landmark study where more than 150 men with metastatic castration-resistant prostate cancer donated a biopsy of their tumor for analysis, and a careful analysis of the mutations that tumors included was carried out and published. And these analyses showed a whole lot of interesting findings, but amongst them the fact that DNA repair genes are often mutated in advanced prostate cancer, and that gives us some important clues as to what we might be able to do about that. Not too long after, Colin Pritchard and his team published in the New England Journal of Medicine findings that many of these defects in DNA repair are actually inherited and carried in the DNA across generations. And the most common of them was actually BRCA2 or BRCA2, a gene known to be associated with an elevated risk of breast and ovarian cancer. So there are connections between breast cancer and prostate cancer that were previously not expected. It turns out, as we've gotten to know these data, that if you take patients with advanced metastatic hormone-resistant prostate cancer, about 20% of them have one of these mutations, and about half of those are inherited and half of them arise as new mutations in the cancer itself and are not passed on to the next generation. So in that context, a class of agents called PARP inhibitors have been studied. PARP inhibitors are known to be potentially useful in tumors with certain DNA repair defects. And there have been several studies of PARP inhibitors. I've chosen in the interest of time to show you only one, the PROfound trial that looked at Olaparib. But there's a second agent called Rucaparib, and there have been a couple other studies of Olaparib that are worth looking at when one has a bit more time. So this study, however, I think taught us the most about the current role of PARP inhibitors in prostate cancer. Here, men with metastatic castration-resistant prostate cancer who had not received chemotherapy but had received either enzalutamide or abiraterone, so one of the two most commonly used next-generation hormonal agents, and they were randomly assigned to receive a PARP inhibitor, Olaparib, or the other hormonal drug. So enzalutamide-treated patients got abiraterone, abiraterone-treated patients got enzalutamide. And there were two cohorts. The cohort A had the most common mutations, BRCA1, 2, or ATM. And cohort B had any of a number of other mutations in this DNA repair system. They're listed at the bottom of the slide, and there are a number of them: BARD2, BRIP1, CDK12, CHEK1, so on and so forth. There's a whole family of these genes that are relatively rarely mutated, but they do occur. As is commonly the case for these studies, and you can see in the table, the median age of these folks was close to 70. Now, this busy slide shows you some of the most important findings of this study, and this looks at cohort A, so patients with BRCA1, BRCA2, or ATM mutations. And on the left-hand side, you can see progression-free survival, and on the right-hand side, on the top of the slide, you can see overall survival. And both were favorably impacted. They were statistically significantly improved. So in patients with one of these three qualifying mutations, we see a benefit in terms of both cancer control and overall survival. And given that cohort A was the larger part of this study, it's not entirely surprising in panel C down below that we see a cancer progression benefit when cohort A and cohort B are combined. But when we look at cohort B alone and look at overall survival, whether we adjusted by crossover or not, meaning, you know, these patients, when they progressed, could take advantage of a PARP inhibitor, it didn't matter. There really isn't much of an effect. And so cohort B was disappointing. And it looks like these other mutations, at least taken together, do not identify patients that benefit a whole lot from PARP inhibitors. And this is some summary data on individual mutations. And the point here is not to go through each of these mutations individually and talk about them, but more to drive home the point that the mutation matters. And so these are results from two different studies, PROfound, which I showed you, and a prior trial called TOPARP-B. And you can see that for BRCA2, there's a clear difference. Progression-free survival, 11 months versus 3.5 months. Down below, response rate of 80%. Those are patients that clearly derive some advantage from this treatment. The other mutations, less clear. That's why cohort B was not so successful. ATM has been a bit disappointing. That was included in cohort A, but really the signal in ATM mutated patients is not so clear. Some studies have identified PALB-B2 as a mutation that may be sensitive to PARP inhibitors, but we're going to need to learn more about this. And not every mutation here is created equal when it comes to sensitivity to PARP inhibitors. So what we can conclude about PARP inhibitors is that there are two agents that are currently approved. I didn't show you the data on Rucaparib. About 20% of patients harbor qualifying mutations, and this is one of the reasons why looking for these mutations has increasingly become a part of the standard work that we do in taking care of patients with advanced prostate cancer. We can look at these mutations in tumor samples or in the blood where circulating DNA from the cancer can be found, particularly in patients whose disease is extensive and DNA shedding into the blood is substantial. We know that about half of these patients get their mutation through inheritance. And so if we find one of those mutations in the tumor, testing for carrier status is important for informing the family. And we know that not all mutations are associated with a response, but BRCA2 looks like a clear winner for PARP inhibitor therapy. Now, side effects of these drugs are also a consideration, including from treatment of patients with other cancers, a concern that in the long term, PARP inhibitors can predispose patients rarely to develop pre-leukemic conditions. So we have to pay attention to both the risks and benefits of therapy, but certainly in the most advanced prostate cancer patients who lack high quality treatment options and harbor one of these sensitizing mutations, PARP inhibitors have entered into routine use, and a number of studies are evaluating additional PARP inhibitors and additional disease states in prostate cancer. And so I would expect to hear more about this class of agents in the future. With that, I'd like to thank you very much for your attention today. It's been a real pleasure to be with you via video, and I hope you're enjoying the summit. Thank you so much.